anything, the right side looks slightly higher than the left. Yeah. So medically, we might use the word cephalic, yeah, cephalad, towards the brain. Okay, and when it's going this way, we would say it's going more chorded, towards the chorda equina. So in this case, we might say it's more slightly superior. It doesn't mean it is. Yeah, but on first palpation, come down and up, and we come underneath there. So the ischial tuberosity on the right seems to be slightly more in that direction than the left side. From here, what we can do, palpate the PSIS. PSIS is in line with S2, yeah, from there. But if you think about where we are, so you've got the ischial tuberosity and you've got the PSIS here, then obviously there's a bit in between. That ligament, and my thumb is on the ligament now. Okay, so I can roll the ligament and I can push on that sacrotuberous ligament here. Okay, so there's the ischial tuberosity. So that's ligament is, so I'm over it now. So it's in this vertical direction.
That's piriformis, right?
No, that's the sacrotuberous ligament, because piriformis will come from S2 to 4, more over here. There's piriformis. Okay, whereas the ligament is here. Yep. Okay, so it comes up like that. And then the corner of a bone is easy, that's why I chose her, because she's slim. Okay, so we can palpate the corner of the sacrum. So the corner of the sacrum is here, we come across, come down a bit, and then excuse my thumb. So the coccyx is here, so you come up and across in the corner of the ILA, and that's where the ligament will connect down to the tuberosity. Remember, bend your knee please. The bicep femoris will connect to that, and the bicep femoris connects from the head of the fibula, which then connects to the first metatarsal from the tibialis anterior. So it connects in this fascial chain. Then from here crosses to go up to the occiput. Yeah. Now, so excuse me. So if you expose that sort of area of the back, sometimes you can see what we call the dimples of Venus, and they are called that. And they would sit around the sacral sulca. You might notice the dimple in the lower part of your spine. You don't really see it so obvious in here. So the PSIS there. Now the L5 will be where my thumb is, and the PSIS will be here. The iliac crest will be on L4. Okay, so from there, crest to 4, PSIS, and I can just come down. There's a natural dip that forms, and that dip will be what we call the LS, the lumbosacral junction here. So below my thumb is S1, but above my thumb is L5. Okay, yeah. So I'm on the L5 spinous process, and below it I'm on the S1 spinous process. Now, from there, if you find the PSIS and take an imaginary line between, almost like a triangle, between the two PSIS, then what you're going to do is from there you're going to literally just roll over. Oh, interesting. Roll and just let the thumb sink. If I'm going to say anything, I feel more tone in this left muscle, but what I feel is my thumb on my right seems to sink in further than my thumb on the left. Okay, so my right thumb seems to be what I call deeper compared to my left thumb, that seems to be slightly shallow. I'm not saying anything yet, it's just observation, because we haven't done any testing, that sort of thing. But on first palpation, my right thumb seems to sink in. So if we are looking at it from a sacral perspective, because we're trying to add things together later, so from there, if my thumbs are on there, and I'm saying my right thumb goes deeper, then there might be a...
Left on left.
Yeah, so it might, well, you don't know yet. Okay, so it would be left, you could say it's a left on left, but then it could be that this side has gone forward, so we think this side is nutated. However, it could be this side. This side is actually, instead of this one going forward, this one's actually come back to the left on the right axis. Okay.
Can you go to the apex?
Well, you could. Yeah. You could. Yeah, you could. Okay, so if it's deeper on the right, Now with a lumbar spine, is she lordotic? Is she neutral or is she flat?
Neutral.
Okay. Now, if you're not sure, what you can do is maybe if you just tilt anteriorly. So that would be more, so she can go into lordosis, and then if you can do the opposite, so that would be into the flat back, okay, and then just go where you are, okay, so she's somewhere between the two, isn't she? So she's not really flat, and she's not really lordotic, so she'll probably be somewhere towards that. Now, if she was particularly flat, flatten your back, and then you decided that the sacrum has come back, then the shallow side will be the dysfunctional side. However, if she's gone forward and she is nutated, and then the right side is deep, then you know that it is deep on the right and is rotated left on left. In that position. Okay, relax.
Pull forward. It's pulled forward.
So you could decide if it's flat or lordotic, then that dictates the position of the sacrum. And then you could clarify, if she is rotated, is this side higher? Because when I show you the treatment, it works quite well. If that side is deep on the right, I will use this ILA, and I come in this like this, and I'm going to mobilize it. Because I'm trying to tilt it. And that's quite nice because it levers the sacrum up on the right side, but also whatever I do to the sacrum, as I push here, the sacrum is going to come which way?
Right.
Back, which means the innominate is going to go slightly forward. Yeah, good. And not only that, because I am extending the sacrum, it's going to encourage the lumbar to go into flexion. Okay, so you can see already by doing one thing, it has an effect on something else, Remember, whatever you do to A will affect B and C. Yeah, okay, but don't worry about it yet. So, ischial tuberosity, sacrotuberous ligament, ILA, coccyx, PSIS, S2, PSIS, L5, L4, sacrosulci. Just wait. Maitland says, just wait for the thumbs to sink. Okay? Because you might find, ladies during menstruation, you might find you have edematous hairy tissue around it, and you might just have to wait for the tissue just to give to allow you to sink. And you might find ladies' pregnancy, ladies certain times of the month, you might find this part of the back might ache. Okay, yeah, menstruation times, yeah, where you might find the body's in preparation, if you like. So you might find it might ache because of the swelling. Swelling causes pressure, pressure causes pain because it irritates the nociceptor, the pain receptors. All right, so swelling, pressure, pain, signals, yeah, off it goes. Yeah, but it's not an SI dysfunction, it's because of that sort of period of time of the month, things like that.
But they'll generally be able to tell you.
Of course.
Yeah.
Yeah.
I mean, if women will,
Yes. Hopefully.
Yeah.
Yeah. Yeah. Okay. Come on to L5. You can also do something called a spring test on L5. Is that okay, Liz?
It's weird, but it doesn't hurt.
Yeah.
Yeah.
Okay. So you can spring L5, and then come on. So you're almost like looking at the mobility on the vertebra here.
So you're on the spinous process?
On the
That's a bit
spinous
sore,
process.
that one.
Yeah. So on the spinous processes. There is a test. That is a test in itself called the L5 spring test. If the spine rotate, come back.
Right.
If it's flat, when I come on to L5, what do you think it
Should
feels?
spring a lot, shouldn't
It'll be stiff. If you go into lordosis, okay, when you spring, it will spring more now, so you'll be able to mobilize it more. Because it's more of a neutral spine. Yeah, lordosis, it's natural. Whereas a flat back is not. Flat back is flexed. Flat back is degenerative spine, like a hip. Okay, so you have a degenerative changes in the hip. It'll be inflection, you want like extension. Things like that. Also, if you've got a flat back and you're 65, 70, it's probably because you've got L5, L4 degenerative changes to it, OA, yeah, spondylosis, yeah, to it. And that's the way it is because the body is self-fusing. Okay, and it will fuse you into flexion, yeah, things like that. But like an ankylosing spondylitis, when it fuses, what you end up having, I feel like I've got one of them today. Very stiff. Was it causing your spine? Because it starts here, left and right SI joint.
Kyphosis?
It'll cause a kyphosis, but what's another name for it? An ankylosing spondylitis.
Oh,
So if you have an X-ray of the spine, instead of seeing the 23 individual discs, it will look like one fuse called bamboo spine. Yeah, so it looks like one rod. Okay, and as it's developing, it will cause flexion. And then the downside is that the soft tissue, because ankyspon, they don't know, is a disease-modifying drug you would take, like methotrexate or sulfasaline. But basically, it's the soft tissues, as in the ligaments and the discs that ossify. This process is called enthesopathy. So you might have a greater trochanteric pain because the enthesis of the tissue, like the Achilles tendon, also affects the eye, linked to Crohn's. And as it goes up, obviously where the ribs come in, okay, and you have the little demifacets, the costotransverse junction points you, they fuse, so you lose in respiration. Okay, because you can't breathe in as fully. You can only have between 2 and 5 centimeters of breath expansion if you measure you. Okay, and then you tend to lose that, which means you probably die of some form of respiratory dysfunction. Yeah, as a result of the AS. Okay, as it goes up. But it is linked to other things as well. Yeah, what you do, mobilize it, but not manipulation too much. Okay, exercise is a key. Yeah, heat. Yeah, that sort of thing. But it will slowly manifest its way. Sometimes it'll hit quick, but sometimes it's slow process. Yeah, probably by then, because we did the blood test. Yeah, they're probably on some form of serious medication to calm it down. Okay, it'll never go away, they don't know why. Women sometimes have it, or someone's carried with gene opacity this time. Yeah, something can happen, not many. It's only men. So we did some palpation to the sulci. Yeah, the L5 here. Have a lie on your back, please, so you face up. Screw up the pillow behind you. Good.